Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. We'll just give everyone another minute or so to join before I get started with today's topic. I hope you can hear me loud and clearly. If you can hear me, please just type a 1 into the chat pad. I also want to welcome our viewers that watch this on replay, but I also want to welcome our viewers that are on the live show here. And like I said, today's topic is how to handle doom and gloom from ICU teams when your loved one is critically ill in intensive care. It is one of my favorite topics when dealing with families of critically ill patients in intensive care. And I can talk about it endlessly because that is what I'm dealing with almost on a day-by-day basis when talking to families in intensive care all around the world. And, we'll cover this topic in depth today. So let's just give it another minute for everyone to come on, and then we'll get on to today's topic. Just give it another minute for everyone to join, and then we'll get started. Okay, let's get started. So how to handle doom and gloom from ICU teams when your loved one is critically ill in intensive care. So before we go into today's topic, what makes me qualified to talk about the topic how to handle doom and gloom situations from ICU teams in intensive care when you have a loved one in intensive care? Once again, my name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. I am a critical care nurse by background, having worked in intensive care and critical care for nearly 25 years in 3 different countries, where I also worked as a nurse manager for over 5 years in intensive care. I have been consulting and advocating for families in intensive care for over 10 years, as a matter of fact, since 2013, as part of our intensivecarehotline.com consulting and advocacy service. I have been answering thousands of questions over the years for families in intensive care, and you can see that in my video and blog post library at intensivecarehotline.com. I am also the founder and managing director / CEO of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are providing a home care intensive care service predominantly for long-term ventilated adults and children with tracheostomies. And we are sending intensive care nurses into the home as a genuine alternative to a long-term stay in intensive care. And we've been doing that also successfully since 2012. We are currently operating all around Australia in all major capital cities, as well as in regional and rural areas. We are an NDIS approved service provider, also TAC in Victoria, ICARE in New South Wales, and IISQ in Queensland, DVA, all around Australia. And we have also received funding through public hospitals, departments of health, as well as private health insurances. So with Intensive Care at Home, we're also providing level 2 and level 3 NDIS support coordination. But without further ado, let's look at how to handle doom and gloom from ICU teams when your loved one is critically ill in intensive care. And, by handling those situations over and over again, especially the doom and gloom, I can confidently say that with intensive care hotline as well, we have saved lives with our consulting and advocacy for patients in intensive care. And you can look up the evidence for that through our hundreds of case studies. You can look up the evidence on our testimonial section. You can look up the evidence on our podcast section where we have interviewed clients. So there's an abundance of evidence that getting help in intensive care from a professional that stands on the outside but has worked in the environment for decades will give you the results that you want, need, and deserve. So how did I come up even with the term doom and gloom when it comes to families in intensive care? Well, this is actually a term that families have given these situations over and over again. Families come to us and they say, I can no longer stand the doom and gloom and the negativity from intensive care teams. This is a phrase that I've heard probably hundreds of times over the years from families of critically ill patients in intensive care. So this is actually a term that comes from lived experience from families in intensive care. They have used this term over and over again. So how to handle it? Well, first off, you don't need to live in the ICU team's reality, right? Like I always say, you cannot control other people, but you can control how you respond to that. You are 100% in control how you respond to that, right? So you can buy into the intensive care team's doom and gloom and negative narrative, or you can create your own narrative. But you can probably only create your own narrative if you get help, get the insights like I can give you here. Because I've seen thousands of critically ill patients over the years, and I know about outcomes, I know about, many, many situations, and what happens if you are changing the narrative, what happens if you get consulting and advocacy, what happens if, start asking the right questions, which leads me to the next step. Don't work with incomplete information, right? So what do I mean by that? Well, most families that reach out to us have incomplete information, right? They say, like this morning, I was on a call to a prospective client who said, oh, well, my father is on BiPAP in ICU. When is CO2 coming down, right? So the CO2 is like in its 90s, which is way too high. Normal CO2 levels are 35 to 45 millimeter per mercury. And he says, well, it's just been started on BiPAP yesterday. What's a reasonable time frame for CO2 to come down? I said to him, well, it's a question. The answer on that question really it depends, right? It depends on what BiPAP settings is he on. It depends on, what medications is he on. It depends on what arterial blood gases are showing. It depends on whether he's breathing spontaneously or whether he's not breathing spontaneously. So the answer to a question like that is really that it depends. So, and also that leads me to that the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. This is another classical example that if you don't know what you don't know and you don't get help, you almost have no choice but to buy into the doom and gloom and the negativity of intensive care teams. Now, I can give you countless examples. When I worked in intensive care at the bedside, there have been some situations where I felt that the doom and gloom of intensive care teams has led to patients dying. Families weren't standing up for their loved ones. It was easy for intensive care teams to create that narrative of, oh, well, this patient, your mom, your dad, your spouse, your brother, he says, going to die anyway. So let's just wind up everything and let's do what's quote unquote in the best interest of a patient. Well, what's in the best interest of a patient is what a patient and the family wants, not what intensive care teams want. But I could only see that, you know, the negative narrative that is created in intensive care with time, with experience, you know, also with doing more intensive care at home work. So, you know, I might have a very unique experience here, but I think it's a very valid experience because most intensive care professionals don't have experience with intensive care at home, for example, right? Most intensive care professionals are employees of a hospital, and they, you know, say whatever the hospital wants them to say, right? So whereas here, you know, we come from a very different perspective, and I'm here to help you and your families to steer the doom and gloom from ICU teams, right? So I'll give you other examples. You know, many times have I had clients on the phone, and they say things like, oh, you know, tomorrow at 3 o'clock, ICU says we're going to withdraw treatment on my loved one, and they're going to die because it's quote unquote in their best interest. I've had many situations like that, and you know, we turn it around every single time because you can't just withdraw treatment and end someone's life without consent of either a patient or a family, you know. And families are often gobsmacked. That's what they're seeing, that ICUs think they can just do that. But when it comes to situations like that, ICUs are not operating in a vacuum, even though that's what they would like to pretend, that they operate in a vacuum and that they can do whatever they like, right? So asking the right questions when you have a loved one in intensive care is absolutely critical, right? You can't just ignore what's going on, right? So what you need to do to handle doom and gloom, number one, you can buy into it, right? Or you choose to create your own narrative, and you choose to create your own reality. So what I mean by that is, you know, first thing that you need to do is get access to the medical records. Talk to us here at intensivecarehotline.com. Get help, get professional help, get outsider help, and make sure you get that second opinion, right? Also, just because intensive care teams might think, well, it's not quote unquote in the best interest of your loved one to live, and they may not survive. And well, again, what do you think is important for your loved one? Do you think your loved one can live? Do you think your loved one wants to live, even though they might be permanently impaired, right? Those are questions that you need to ask yourself, and that nobody can answer for you but yourself, right? For example, just last week, I read an article on Professor Pope's website, the Medical Futility blog post, and I recommend you check out Professor Thaddeus Pope. He's a medical futility lawyer in Minnesota, in Minneapolis, in the US, and he's an expert on end-of-life care law, bioethics, and you know, his blog is amazing. He's always giving the latest updates about, you know, end-of-life law and so forth. He sent out a blog post last week, something along the lines of that more and more hospitals are being forced to keep people alive even though they're technically brain dead, right? And I'm not here to take either side. I am here to educate families in intensive care. I'm here to educate you about your rights. I'm here to educate you about, you know, how can you make sure you get what you want on a cultural, on a spiritual, on an ethical, on a moral level. You know, that is up to you and not up to anybody else. But going back to Professor Pope's blog post this week, so there is a hospital in the US somewhere, I can't quite recall where it was. They're keeping someone alive, or even though they're brain dead, and apparently the court has decided in the family's favor. In many jurisdictions all around the world, if a patient in intensive care has technically been declared brain dead, they're also often legally dead. But they can be kept, quote unquote, alive on life support, right? So what's the definition of death? Is it the cessation of heart rate? Is that the definition of death? What if you can continue with a heart rate by keeping people on life support, and even though their brain might be dead, are they still dead? I am certain that some people will challenge, the definition of death, that when someone is brain dead, that they're also legally dead. I'm sure there's many religions that would challenge that. I'm not here to make judgment here. I'm just here to watch with much interest what is actually happening in the real world. Do some people believe if my loved one is quote unquote brain dead and they stay on a ventilator and life support for the next 6 months, that they will wake up again? Is that what some people believe? I don't know. But I do believe we need to create space. We need to create more space for people's beliefs in this arena, besides just the medical and the nursing approach that we all know is there and is important, of course. But what are people's beliefs? It's not black and white. It's not a one size fits all, as ICU teams always want people to believe that, clinical care in ICU, it's just a one size fits all. Well, people are very unique, very individual, and we need to create space for that. Case in point, again, we are currently working with a client who has their young brother and son in ICU since early January with a hypoxic brain injury, and he's not waking up. And ICU was, tried to declare him brain dead, but he wasn't brain dead, and he isn't brain dead, but he's, minimally conscious and he's not waking up. And, the ICU there has been very much doom and gloom, and they don't want to do physical therapy. They don't want to mobilize him. How do you get someone with a brain injury better if you're not stimulating them? He's been lying in bed for 2 months now, and you can't get someone better without stimulation. We don't know whether this young man is going to wake up or not. We don't. Chances might be slim, but one thing is for sure: if you're not trying and if you're not stimulating him, it's not going to happen. I have not seen people waking up and getting better if they're not being stimulated, if they're not getting mobilized. Imagine, as a healthy person, you're lying in bed for 2 months. Well, you wouldn't be healthy after 2 months. So this person is already sick, and then you're confining them to an ICU bed for 2 months. It can't be healthy, right? So again, what is important in a situation like that? You need to put pressure on the hospital from day one. You need to ask the right questions from day one, because if they're creating the doom and gloom scenario, and you are not prepared with the right questions, with the right help that you need, you will be fighting an uphill battle. So, it's critically important. Get access to medical records. Get you and me on a call with intensive care teams, and you will see I ask all the questions that you haven't even considered asking, right? And you will see that the situation is going to change very quickly. Dawn, nice to see you again. This sounds exactly like my grandma after her stroke. No PT, no moving her around, nothing. This was from the hospital. Yeah, I'm not surprised, Dawn. The hospitals are very quick in giving up, which makes it easy for them to create this quote unquote doom and gloom. It's terrible. Your grandma might be in a better place if they had focused on the positives, and that's another strategy for you, or for any family for that matter who's watching this. If the ICU team starts about the doom and gloom, well, bombard them with the positives and say, hey, my grandma was pretty good before this. I want her to get back to that. I think she can get back to that. Here is what my grandma wants. The problem especially with hospitals in the United States is, they're rushing to trach and peg and then want to send patients to LTAC out of sight, out of mind. They don't want to deal with it. They don't want to take responsibility for rehabilitating people to the best of their abilities. It's almost like a convenience now. Oh, we do trach and peg if we can't win patients off the ventilator, and we'll just send them to LTAC. It's absolutely shocking. It is absolutely shocking. And We need to break the cycle to create a better system, because the system sucks. The system is flawed. The system is broken. We can see it every day. Just this morning, I was on a call again to another prospective client who said his father was in hospital for a few days with a pneumonia, then ended up going to rehabilitation. He wasn't in ICU, he was just on a regular floor, goes to rehabilitation, and one day later, he's in an ICU in another hospital on BiPAP now. This is the whole madness by hospitals trying to outsource everything to another place rather than taking responsibility for a patient's journey, right? Create teams around a long-term patient if that's what's needed, but don't send them from place to place, no one taking responsibility for good outcomes. We created a system that works for the system, but it doesn't work for patients and families, which is terrible. We need to create better systems. We need to create care where people are held accountable for outcomes. There's no accountability either, which is also one of the reasons that hospitals are creating these doom and gloom scenarios. Another important point here is that most patients in ICU survive. So the odds are in your loved one's favor, right? Look, I haven't got the latest statistics. I'm sure there's statistics coming out every year. Roughly 90% of intensive care patients survive, stay in intensive care. Now, those statistics vary slightly, of course, and they probably would have been lower during COVID. But, pre-COVID, it was sort of 90% of intensive care patients approximately survive. So, you got to go into a situation like that with the mindset, well, the odds are in my loved one's favor. So, why are they creating a doom and gloom scenario? Right? So it's really important for you to understand the research that's out there, to understand what is actually really happening. Here is another important point why you need to understand what the doom and gloom really means. So let's just say, let's just take your grandma, Dawn, and your grandma goes into ICU with a stroke, and the ICU says to you, hey, Dawn, we just need to do some work with your grandma for the next 2 weeks. We need to give her some treatment. We need to, maybe thrombolyze her. We need to, ventilate her for a couple of weeks, and then she'll wake up, and then 2 weeks later, she'll be out of ICU. Let's just say they did that. They gave you hope. They gave you a plan. They gave you a strategy, and then, your grandma isn't getting better. You could potentially sue them, right, for trying to mislead you. So by them creating a doom and gloom scenario and negativity right from the start, they're managing their downside. So what I mean by that is they are protecting their downside, which is you can't sue them if they tell you, oh, well, your grandma is not going to live, she's going to die no matter what we do, and then she's going to live. Well, they have created a scenario that you would be accepting of, and they keep your expectations low. They're managing your expectations, right? And they're managing your expectations to a degree where you be happy for any little win, And if your grandma isn't going to make it, or anyone for that matter, they can tell you, oh, well, I told you so. I told you right from the start. She's not going to make it, right? So it is critically important that you read between the lines. Critically important that you read between the lines and that you come up with your own conclusions, right? Most families are too timid to come up with their own conclusions. Most families are too timid to get help, right? How can you not get help when you have a loved one in intensive care? It's a once-in-a-lifetime situation that you can't really afford to be getting wrong, right? I can give you some other examples. We were working with a client a couple of years ago who came to us saying, hey, my dad fell off the scaffolding head first, the terrible situation, head first down a scaffold, cardiac arrest, traumatic brain injury, ended up in ICU. Was a terrible situation. A young man, he was in his late 50s, not looking good, was having high intracranial pressures. The ICU wanted to pull out, wanted to withdraw treatment, had already given the family a timeline. Family reached out to us, and I remember, talking to doctors and nurses and saying, hey, why haven't you educated the family about the option of a tracheostomy? Oh, well, this man shouldn't have a tracheostomy, won't survive, and blah, blah, blah. Anyway, cutting a long story short, the patient did have a tracheostomy, and the patient did survive. And the patient even came onto a podcast with me here at intensivecarehotline.com. So have a look at our podcast section. There's a podcast there from maybe about a year ago with Ariana and her mum and her dad and her brother. An amazing story. The doom and gloom was shoved down their throat, for lack of a better term. And he survived against the odds, and he managed to get on a podcast a year later. And if we hadn't intervened, he would have died. They would have stopped everything. So, the survivor stories are out there. Unfortunately, only the survivors can talk, which means, you have to ask the right questions. You have to get the right advocacy. And there are many other stories, where we help people survive. Simple as that. And also, even if it is true that your loved one may not survive, right, you would still want to have an end-of-life situation on your terms, right? Once again, what's happening in end-of-life situations? Well, it's a case of tomorrow at 3 o'clock, we're going to withdraw treatment. Well, you may not be ready for that. Is this something that should happen in a hospital? Is this something that can be done at home? If I had $1 for every client, every patient that I worked with in intensive care who said, well, I don't want my loved one to die in an intensive care unit, I want them to die at home, right? Which led me to set up intensive care at home. Now, a lot of our patients can live for decades, right? But with intensive care at home, there's also an option for end-of-life care at home, for palliative care at home. So, you got to read between the lines. You got to look at what's out there. You got to make up your own mind, and don't let other people think for you. You got to think for yourself. You got to get access to the medical records. You need to have someone like myself and my team look over it to get a second opinion, right, before it's too late, right? Dawn, you're saying you want to take your grandma home. We had a doctor try to force us sending her to sniff last week. My mother is traumatized by the event. I think this also traumatized the caseworker. Yeah, I do remember talking to you, Dawn. I think your mum went from ICU to LTAC, and now they probably can't wean her off the ventilator, which is something I could have predicted, and now they want to send her to sniff. Often what happens is in the US that patients go to LTAC, they have a 30-day window to be weaned off the ventilator. It's not going to happen most of the time. LTACs they don't have the skills to wean patients off the ventilator that are more complex, right? That's why they need to stay in ICU. And then if they don't get off the ventilator within a 30-day period, they want to send them to SNF. SNF stands for Skilled Nursing Facility, and things are going from bad to worse. You're saying the caseworker told us she's never seen a family advocate. We have. Well, good for you to keep standing your ground. Don't be pushed around. It's good that you're standing your ground. Don't be pushed around. For anyone watching this that's in the US, the trajectory, they've already laid out the trajectory for your loved one. LTAC from ICU with a trach and a PEG. 30 days at LTAC often if your loved one can't be weaned off the ventilator, then they want to send them to a SNF. Now, an LTAC, from my experience, is not even the better version of a nursing home, right? And then SNF is even worse, right? If you're watching this and you're in Australia and you're having a situation like that where, you have someone with a trach long term, or with a PEG, or with an escalation tube, we can take your loved one home with intensive care at home, right? It's all doable. Same with you, Dawn. You could take your mum home with intensive care at home if it's available in your area. We can help you privately. I can't remember where you were, Dawn. I know I've spoken to you on the phone briefly, but I can't remember where you were in terms of location. Going home is an option, but it has to be safe. It has to be safe. And you can't go home with a trach and a PEG without ICU nurses 24 hours a day. Okay, you're in Texas. Are you in Dallas? Are you in Dallas, Dawn? Where are you in Texas? Because we have staff in Dallas. Anyway, while I'm waiting in Austin, okay. Right. Just remind me, Dawn, your grandma does have a trach and a PEG, doesn't she? Now, also, especially in the US, when you are in ICU and you are faced whether you should do a trach or no trach, or whether you should do a PEG or no PEG, don't do a PEG right from the start. Don't do a PEG right from the start. It can be a PEG can be the stopping point to get your loved one to LTAC. Many LTACs don't take patients without a PEG tube, right? So, but also a lot of families come to us, sort of saying, oh, they want to do a trach tomorrow. Is this the right time? You got to look at those things from day one. From day one, right? You can't just wait until the day before and then wonder, should my loved one have a trach or not? You need to ask from day one, how can I avoid a trach? How can I get my loved one off the ventilator as quickly as possible? You need to ask the right questions. Very, very important. You need to have someone from day one that can give you a second opinion. The biggest question you should be asking when you have a loved one in intensive care, especially on mechanical ventilation, is, are they doing everything beyond the shadow of a doubt to get my loved one off the ventilator? That is a much better question to ask. It is the most important question to ask, right? I can't believe how many families come to us. Like last week, this is actually something that triggered me to make this video today. A gentleman who said, oh, my wife is in intensive care. She's on a ventilator. They want to do a trach. Can you help me take her home? Right? And I say, yeah, sure. That's core business for us. We can take patients home on ventilators. Sure, with trach, that's what we do all day, every day. But I said to him, but why would you buy into that narrative? Have you asked them how to avoid the trach? And he said, now they told me she can't avoid the trach. And I said to him, are you just taking this for face value? Do you know what difference it would make for your wife to go home with or without a trach? Do you know what difference it'll make for you and for your sanity and for your peace of mind to take your wife home with or without a trach? And he kept going back to saying, yeah, but they told it's not possible. Well, how do you know it's not possible if you haven't tried? How do you know it's not possible if you haven't gotten a second opinion? Right? Most patients in intensive care don't need a trach. Right? Most patients in intensive care don't need a trach. Right? And the few who do should be able to come off ventilation and tracheostomy while they are in intensive care, if they're doing all the right things, right? Have a look online at the reviews for LTACs. Have a look. And what picture are those reviews painting? A pretty dismal picture. Dawn, so your grandma does have trach and peg. Right. Now also, if anyone wants to join me here on the call and wants to talk to me directly, click on the link here. Right. Click on the link here and then you can join me here and talk to me directly. Otherwise, I'll move on with some questions that have come in during this week. Let's look at some questions that have come in during this week. If you have questions in the meantime, please type them into the chat pad or join me on the live stream here and talk to me directly. The link is in there, the StreamYard link. Let me have a look at the questions that have come in this week. There we go. So here's a question from Nolan, who says, when is it the right time to remove life support? Well, this is a very difficult question, but there's two scenarios here, Nolan. One scenario is, why do you want to remove life support? Do you want to remove life support because your loved one is getting better, right? So when you remove a ventilator because it's no longer needed, well, that's a good thing, right? Or is it you're removing life support because it's the next step to end of life? So, so if you want to remove life support because your loved one is getting better and they no longer need it, well, that's a good thing. Any time is good for that, right? Assuming they don't need to go back on it. On the other hand, if you're removing life support because it's an end-of-life situation, well, is there ever going to be a good time? Should they stay on it? Have they tried everything? Right? We are finding most of the time they haven't tried everything. They have been withholding information from you or potentially treatment options. Right? So got to think about that. Also, if you are talking about removing life support, is this your choice? Is the intensive care team pushing you towards it? Those are all questions you need to ask. Also, is your loved one, assuming we are talking about end of life here, also, is your loved one in a real or in a perceived end of life situation? Right? So what's the difference? A real end of life situation is a situation where no treatment, no surgery, no medications, no nothing can save your loved one's life. Right? That's it. A perceived end of life situation is when intensive care teams tell you, well, it's all hopeless, your loved one's going to die, and they haven't even told you about all treatment options available. Right? It's a perception that your loved one is going to die. Another thing you've got to look out for, especially when the intensive care team is telling you, well, it's all hopeless and your loved one isn't going to make it. Well, every day they stay alive, the narrative, and the doom and gloom narrative in particular, is collapsing. It's collapsing. Right? You have to wonder about their clinical judgment. If they're telling you your loved one is going to die, but they're still alive after 10 days, 14 days, 20 days, you have to question the narrative and you have to question their clinical judgment. It's almost like every day, every hour, your loved one's going to live. The narrative is flawed. The narrative is flawed. Next question from Amanda, who says, "Hi Patrick, my mom won't follow commands of sedation." Well, that's a great question, and we get the question all the time, but I think, there are many questions around that. So if someone's not waking up after an induced coma in intensive care, there are a number of questions you need to ask. One of the questions is, does she have a brain injury? Did she have a stroke? Right? If so, a specialist should be consulted. A neurologist should be consulted. Maybe a CT scan of the brain should be done. Maybe an MRI scan of the brain should be done. Maybe an EEG of the brain should be done. Right? Moreover, you have to look at, okay, what sedation was she on? Was she on propofol? Propofol is short acting. That means, when you give propofol, patients go to sleep pretty quickly, but they also wake up pretty quickly most of the time, right? So that's why propofol is short acting. Okay. Now, if she's not waking up after she had propofol, that is definitely a concern, right? Then I would move straight away to a neurological consult, right? What are pupils doing? Are they equal and reactive to light? Okay. Also, if your mom has been on sedatives such as Versed or midazolam, how much did she have? Versed or midazolam is long-term acting, so it takes a lot longer for patients to wake up, especially if they've been on it for days or for weeks, right? Versus with propofol, like I said, propofol is short-acting and people should wake up pretty quickly, assuming there is no neurological event, right? And when I say neurological event, I mean stroke, seizures, brain injuries, hypoxic or traumatic, right? So those are the things you need to look for, right? Also, is your mum potentially liver failure or kidney failure? Well, it's your loved one. You don't say, no, it is your mum. Because if she's in liver failure, it takes much longer for the drugs to be excreted, right? It takes a lot longer for the drugs to be metabolized. The same with kidney failure, right? It takes a lot longer for the sedatives to leave the body. Also, for example, if someone is overweight, there's also a tendency that sedatives are pushed out into the tissue, into the fatty tissue of the body, then it stays around there for much longer and also can delay waking up. Furthermore, you mentioned sedatives, but what about opiates? Your mum most likely would have been on opiates as well, such as fentanyl or morphine, right? And with fentanyl or morphine, it can have a similar effect to midazolam. In particular, it's long-acting or longer-acting. It sticks around in the body, and it could simply mean there's a delay in waking up. Next, did she have any paralyzing agents such as rocuronium, becuronium, cisatracurium? If she had any paralyzing agents, that will also delay waking up, because when you give paralyzing agents, there needs to be more sedation, more opiates, and that can delay waking up, right? Next, your mom is simply sick, very sick, right? Anyone in intensive care is sick, and they simply won't wake up because they're sick. They need time to recover. They need time to recover and recuperate. It is not a quick turnaround often, right? It's not a quick turnaround. So you got to be patient sometimes. You simply have to be patient. But in the meantime, talk to a neurologist. They need to get a neurologist involved to rule out any neurological event, any stroke. Now, next question from Christine, who says, "Hi, Patrick. My dad may have to be intubated and he's 2 hours away from me. Can I prevent this? That's a really difficult one, Christine. I don't know why your dad might need to be intubated. Once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And once again, that is exactly what you're dealing with here. You don't even know why he needs to be intubated. You don't know what could prevent that. Does he need to go on BiPAP? Does he need to go on CPAP? That might help him prevent intubation, but it might not. He might have rib fractures. I don't know. You haven't shared that. Does he have lung contusions? Does he have a pneumothorax? Does he have a pneumonia? Does he have ARDS? Why does he need to be intubated? Can they prevent that from happening? Right? Can they use BiPAP, CPAP, high flow nasal prongs, chest physio? Have they tried all of that before intubating him? Right? This would be absolutely critical. Dawn, you want to come onto the call? Sorry, Dawn, I'm only seeing that now. I've got you on stage here now if you want to talk.
Hi.
Hi, Dawn, how are you?
I'm okay. I'm good. So we are, after kind of having a bit of a traumatic week, our ultimate goal for my grandmother is to just bring her home. And we kind of want to see how we can really do that. Like, I explained earlier when you were telling the other story about what happened to her when she had her stroke. She lived in Illinois before she ever moved to Texas. We only moved her to Texas because the pandemic kind of like, we just didn't want her to travel. So we were like, just stay with us. Before that, she was pretty independent. She had a prior stroke. To that, she lived at home by herself, went to places by herself, all that sort of stuff. So she had the stroke here in September, and they kind of like, we had one neurologist tell us it's like a 50-50 when she first went in. She was like, she can go back to where she was prior, or she can kind of be in the state that she was in at the time, which was just kind of sleep and not really moving. It took her about 2 days to actually wake up. And they intubated her, but she was responding actually fairly quickly. Her original stroke, it took her some weeks to wake up. But my mom, who was there with her through that whole ordeal at the time, because that stroke was actually caused, not in what I say a natural way, but it was actually caused by a piece of plaque breaking off in the bloodstream, and that caused her to have the stroke. So when she was in Illinois, all of her care happened in the hospital, and PT was automatic and immediate. Here, it was like nothing. Like, we were doing her, basically her PT and her care. She went to the first LTAC, of course, and that's when we kind of reached out to you. She went to the first LTAC, and she was actually starting to recover. I mean, pretty well. It took her like a week and a half to wean off the ventilator. She was starting to like move her eyes around and follow commands with her eyes, all of that stuff. And then next thing you know, they started giving her too strong of a blood thinner, which was causing her to bleed out fairly quickly. And then she had pneumonia. Immediately she gets into the LTAC and she has pneumonia and CRE immediately. And so we were actually keeping in contact with her primary care physician at the time. And she was just giving us advice, through the portal, and was saying, hey, this is what you can do. And so the big incident happened when we had the doctor at the LTAC say, who actually rounds at one of the major hospitals, say, hey, we don't have access to an infectious disease doctor. And so she was going to let her go back to the regular hospital. We were going to transfer her out. Somehow during all that time, that same day, she was like, "Oh, I got in contact with the infectious disease doctor, and we know what antibiotics to give her to, deal with the pneumonia and the CRE." And somehow it went from, "Hey, you can let her go," to, "Well, if you let her go, it's going to be an AMA situation." So we didn't know what was happening. We were like, "What?" And then she also came back and told us the antibiotic she was supposed to get was Avicaz, and that it was like $1,000 a bottle. And we're kind of like, okay, so what does that have to do with giving it to her? The next day I come back and they give her a different antibiotic. They only give it to her for 6 days, and then they just kind of leave her there. They're giving her x-rays, CT scans every week after, but they're saying no change, no change, no change. And I'm like, okay, if there's no change, why is she still like this? Like, okay, why are we still sitting around? What else do we need to do? And so we were trying our best to get her out, and they just wouldn't let her go without saying, "Hey, you're going to be responsible for her if something happens." So that eventually kind of just led to her going into full acute kidney failure. And then we had to get her back to the regular hospital, to which by that time her kidneys had failed and she just was fluid overloaded. She was like, at that point, about 300 pounds, just most of it fluid. Dialysis ended up taking a lot of that fluid off. They gave her the first antibiotic she was supposed to get, which was the Avicaz. That took about 2 to 3 weeks, and then they got rid of the infection in her chest. But then she developed some other habits, so we were like, okay, well, we'll send her to San Antonio because that's the closest, biggest city with the hospitals and stuff. Um, she was at an LTAC, but it was technically inside of a regular hospital. The doctor there, he worked at the regular hospital, and he sent her out because he said she has some subdural hematomas, which we knew about. But he had the thought of saying, "Hey, they're getting bigger and her brain was shifting." That's what he said. So he sent her out to where she can see a neurosurgeon, which is what at an even bigger hospital. We get to the bigger hospital and the neurosurgeons are saying she doesn't have any of that. We see the subdural hematomas at about 6 millimeters, but we were always told whatever fluid she has would be absorbed by the brain eventually. That's what we were told. So we were like, okay. So they initially fixed some other things she had, like her permacath for dialysis, the peg tube, which popped one weekend, and that, I believe, gave her a blood infection. Now, the hospital she had came from in Austin actually sent her out of their hospital, because they were saying, "Oh, well, her white blood cell counts are elevated." And I kept feeling her skin. She felt warm to me. And just other things were happening, like her leg wound wasn't healing right anymore. And I said, something's wrong. And at this place that she went to in San Antonio, which is technically they're considered an LTAC, they actually caught the blood infection and said she's had this. And so they were treating her for it. They finally treated her for it, but then I guess it might have did too much damage to the point of, like, her wound on her leg is now, it got down to the tendon, basically. It just wasn't healing right anymore. It went from healing, "Hey, we got good skin underneath, great," to her leg is now, they were saying she wasn't getting any good blood flow in her leg. Like, she has it, but it's not enough for them. And so now we had the hospital that she's at now, well, St. Luke's in San Antonio, we're saying, "Well, we think you should amputate her leg." Even though she still moves her leg, she still moves it. When you touch it, she still moves the leg. They were like, the wound looks really bad. And we were like, amputation. And so the other day, they actually came in, they did some more assessments on her. And the doctors and stuff, they actually moved her around on the bed. And she hasn't moved around like that in months. And they were moving that right leg, the left leg that has the big wound on it. And I noticed that her toes actually started to feel warm again, just from her being moved around. And so we're just like, at this point, we're kind of tired. It's like, you get from one hospital, one place, they kind of fix one thing, but they start something else. And it's just like, we had this horrible experience with this doctor last week, this hospitalist. They were like, okay, she has to go somewhere. In Texas, that seems to be the thing. If they fix anything acute immediately, they want to immediately send them out. And so we were like, hey, my mom was like, no, we think she needs to stay. And this doctor, she was just like, she can't stay here. Everything is acute. And it's done. She's done being fixed here. And so we were like, okay, well, we'll send her to a Pam up the street, right? Just because my mom didn't want her to be under this doctor's care anymore because it was just getting crazy. And so...
Dawn, I'm sorry. I only have another minute left because I only go for about an hour.
Oh, I'm sorry.
Right?
But yeah,
I
okay.
only have...
Anyways, yes. Anyways, we want to essentially just get her home, and we're trying to figure out how we can do that. Like, she's in the process of weaning off the vent, but we don't know what the next steps are.
Okay. Do you know how far away she is from weaning off? Has she had any time off the ventilator at all?
Yeah, she's been on and off the vent since her time in the hospital. So, like I said, when she first got to the LTAC, she weaned off. She was off the ventilator within a week. And so other things happened and they put her back on. And so she had been doing spontaneous for the last 2 weeks. And so, yeah.
Okay. All right. Look, Dawn, maybe you can come back here. I'm doing another one next week, but I do need to wrap this up now. I apologize. Maybe we can continue the conversation. I'm back again next week, but I do need to wrap this up now. I will remove you now.
Okay.
Apologize. Nice to talk to you again. All right. So I do have to wrap this up for today. I always have about an hour here to answer questions. So look, if you need help with intensive care hotline, if you need help with consulting and advocacy, we've also created a membership for families of critically ill patients in intensive care at intensivecarehotline.com. If you click on the membership link there, or if you go to intensivecaresupport.org directly, I also would like you to give this video a like, subscribe to my YouTube channel for regular updates for families of critically ill patients in intensive care. I do a weekly YouTube live where you can answer questions here. I also offer one-on-one consulting and advocacy for families in intensive care. I talk to doctors and nurses directly. I talk to you and your families directly. I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one in intensive care. I have worked in intensive care for over 20 years in 3 different countries, where I also worked as a nurse manager for over 5 years. I've been consulting and advocating for families in intensive care for the last 11 years. And have a look at our testimonial section. I can say without any hint of exaggeration that we saved lives. Now, I also represent you in family meetings with intensive care teams, making sure you're not getting walked all over and you have advocacy there. We also offer medical record reviews in real time so that you can have a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. Also, like I said, we also offer intensive care at home. Intensive care at home is available all around Australia in all major capital cities, as well as in regional and rural areas. We offer level 2, level 3 NDIS support coordination. We are NDIS approved, TAC approved in Victoria, iCare approved in New South Wales, NIISQ in Queensland, as well as DVA all around the country. We have received funding through public hospitals, departments of health, and private health insurance. So please reach out for us. And if you need intensive care at home, if you are in the US or in the UK, please reach out to us. We can help you there privately. So that is my wrap for today. I'll do another YouTube live next week. Please note that next week in the US, daylight saving will have started, so the times will slightly change, but we'll announce that it'll be an hour earlier. So at the moment, it's 7:30 p.m. Eastern Standard Time. no, hang on, it's I'm mixing up the times at the moment, but keep an eye. It changes slightly next week with the YouTube live for the start times in the US. Have a great week, everyone. Like the video, subscribe to my YouTube channel, share the video with your friends and families. Comment below what you want to see next, what questions and insights you have. Go and check out intensivecarehotline.com and intensivecareathome.com. Thanks for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days